Clinical case. The patient is admitted to the emergency department for chest pain relating to the jaw. Assessed by the emergency physician, who is left in the resuscitation service and with prior hospitalization for coronary care unit. Enters the coronary care unit service and is left under continuous monitoring with peripheral access of the left upper limb with liquids based on Ranger lactate at 10 cc per hour. The patient is consulted by hemodynamics and is ordered to take a transthoracic echo to be able to start medical orders. A transthoracic echo was performed which showed a depressed VED of 5% and the results were reported to the cardiologist of the coronary care unit, who then started infusion of lemocidmedam for 24 hours, after which the patient was referred for evaluation for heart failure plus a medical meeting for possible priority cardiac transplantation. The patient was left under continuous medication of dobutamine at 5 micrograms per hour for 2.
Patient continue monitoring and management by actions based on hypotension below 16 35 mm of mercury, hair 45 to 47 becs 4 minutes and weight. Oxygen support via nasal cannula at 2 liters 4 minutes. We continue with continuous monitoring while waiting for a medical method to define the patient's conditions. Medical method in which hemodynamics and coronary unit physicians indicate how the patients benefits of the Harman Davis cardiovascular surgery and transplantation which be carried on the coming days. The procedure is explained to patients with consent of ventricular assistance, which will support the heart while finding the optimal donor for transplantation. The patient is taken to operating room.
Patient enters the cardiovascular unit service from the operating room under mechanical ventilation with orotracheal tube number A, commissure 25, supported by AMBU, which enters the transfer accompaniation B, anesthesiology surgeon head of the operating room, attending physician comes with infusions of the sedation scale of -1 with fentanyl 4 mcg, dexmedetomidine 1 4 mcg, and continues with infusion of vasopressin at 2 IU, dobutamine 5 mcg, marijuana 1.37 mg, levosimendam 0.1 UG, infusion of electrolytes prepared in Rangers lactate, 4 ampoules of potassium, 4 ampoules of magnesium at 76 cc, or infusion of lidocaine at 23.3 cc. Today we start the preparation of resuscitation of the patient with on G of astronaut in 100 cc bolus of Ranger lactate of 500 cc laboratory, and the arteriovenous gases are taken, medical orders are continued, and the patient is admitted with two mediastinal tubes, a left chest to be, a right chest to be, and an epicardial ventricular electrode with pacemaker. Patient continues with prescribed infusion, which presents a cardiogenetic shock signs of the Drexcar set venous saturation so the cardiovascular physician indicates hemodynamic therapy. Peripheral arteriovenous cannulation is performed so the doctor indicates infusion of lidocaine to say to 20 cc. Now additional anticoagulating therapy is started with heparin infusion continuous 600 IU per hour every 6 hours, control of PT, PTT, and NR. The patient present extreme bradycardia, saturation, and severe hypotension with a heart rate of 28 bpm, saturation at 60%, blood pressure of 1625 mmHg.
Patients begin cardiological arrests. Código. The patients begin cardiorespiratory arrests. Code blue is activated and cardiopulmonary resuscitation. Code blue is activated and cardiopulmonary resuscitations maneuvers are started. The first dose of adrenaline is administered and if he continues with cardiac resuscitation. After 3 minutes, the second dose of direct adrenaline is administered. Adrenaline and cardiopulmonary resuscitation maneuvers are continued. After 3 minutes, the third dose of adrenaline is administered. The doctor indicated to defibrillate this patient with 200 joules. Pulse was checked, showing low pulse. It was indicated to increase inotropia. Noradrenaline had 0.3 vasopressin, 3 units, dobutamine at 10 micrograms. Continuing with lidocaine signs the patient continues with nofibrillin sinus A5. Amiodarone infusions, sedations with fentanyl, dexmedetomidine, and midazolam. The patient continues in the unit without inotropic or vasoactive support. Awake, alert, orient, with headache, respiratory pattern, tolerant out to venasal cannula, and with hormone. The base without complications remains in the hospitalization service with possible discharge home.